Hey guys, Miss Hill here, and this is Lecture 2 of Individual Module 5.2, PowerPoint 1. We're going to continue this PowerPoint, and we're going to start with talking about stages of labor. So, in the first stage of labor, we have several different things to consider. It's important that you know that the first stage of labor contains 3 phases. In this stage of labor, what happens is the cervix starts to dilate and it goes from 0 to complete, so 0 to 10 centimeters. So the first stage of labor occurs from the onset of labor until complete cervical dilation, or 10 centimeters. And let's talk about the 3 phases. The latent phase is whenever we have mild to moderate uterine contractions. Our cervix is 0 to 3 centimeters dilated, and our contractions are every 10 to 30 minutes, and they last about 30 seconds long. And this stage of labor lasts anywhere from 5 to 5.5 to about 8.5 hours. The active phase is the next phase of labor, and in this phase of the first stage, our uterine contractions are moderate to strong. They are 2 to 5 minutes apart, 40 to 60 seconds in duration, and our cervix is anywhere from 4 to 7 centimeters dilated. And this phase of the first stage lasts anywhere from about 2.5 to 4.5 hours. The transition phase is the last phase of the first stage of labor. In this phase, our uterine contractions are very strong. Our contractions are 1.5 to 2 minutes in frequency and 60 to 90 seconds in duration. And this phase of the first stage lasts anywhere from 1 to 3 hours. Our cervix at this point is 8 to 10 centimeters dilated. And mom goes through a whole lot of emotional things during the first stage of labor, and I want to talk about those. In the latent phase of the first stage, the mom is able to cope. She may have some anxiety of what's to come or what's going to happen, but for the most part, she's very excited and she's able to cope with what's going on. She's not hurting that bad. Her cervix isn't that far dilated. This is your Facebooking stage, right? Mom is laying in bed. She's got her cell phone out. She's texting her friends, "I'm here. I'm in labor." She's Facebooking selfies, so she's able to cope. In the active phase, things become a little more intense for mom. She fears a loss of control, and she's very focused. She has a sense of hopelessness because things are really starting to kick up a notch, and she's starting to really hurt. You can't usually get an epidural until you're about 4 centimeters dilated and your contractions are in a good pattern. So you're really starting to experience some pain in the active phase. And in this phase, moms have that sense of hopelessness, and but they also have a sense of purpose. They have a need to regroup, sort of pull themselves back together to sort of focus on the thing that's getting ready to happen. In the transition phase, this is the get it over and get it out phase. Your mom is completely focused on the task at hand. She has an acute awareness for a need for energy. She feels out of control, and she might have some extreme anxiety about what's happening to her. She's very restless and uncomfortable. At this point, her cervix is 8 to 10 centimeters dilated, so if she's at that 8-centimeter stage, she probably has a lot of pressure, and she wants to push so bad because that's what her body feels like it needs to do. And we, as the labor nurses, are telling her, don't push, breathe through it. And that's very difficult because she's got a lot of pressure, and the only way to relieve that pressure is to push. That's the body's natural response to that pressure you feel in your perineum. But we don't want her to push until she's 10 centimeters dilated. So that's why moms may be very uncomfortable and restless, besides the fact that contractions just hurt. At this point, moms are very inward directed. They focus on themselves. They are tired. They have increased bloody show. And they feel that need to bear down like we talked about. They also have an increased need for partner support at this time. But this can be a difficult time for the partner because this is the time whenever moms are yelling at their partners, right? Make it stop. Get it out. Make this, get this over. So 3 different phases for the first stage and the 3 different types of experiences that mom have during those phases. Those are very important for you to know. The second stage of labor is our pushing stage. So we are completely dilated, and this stage of labor lasts from the point that mom is 10 centimeters dilated until the baby is born. So again, also known as the pushing stage. Mom has a severe urge to bear down, a great feeling and sense of pressure that is extremely intense. Her uterine contractions last anywhere from 60 to 90 seconds. They're about 1.5 to 2 minutes apart, and they are very strong in terms of intensity. So whenever you feel mom's abdomen, these contractions feel like your forehead. They're strong. This stage of labor can last anywhere from less than 15 minutes to up to 3 hours. It just depends on how well the contractions, it depends on that power, and it also depends on the passage and the passenger relationship. It depends on mom's ability to push. In this stage, we experience crowning. Crowning is the appearance of the presenting part at the introitus, or the vaginal opening. So this is where we start to see the head come out. Bloody show increases even more at this point, and the cardinal movements of labor occur. And cardinal movements are positional changes that happen so that the fetus can pass through the birth canal. You might also hear these called mechanisms of labor, and I have a photo of these that you can look at. I don't need you to know what each one of them are. I just want you to know that all of these things have to happen. These mechanisms of labor have to happen so that the baby can move through the vaginal canal. During the second stage, moms feel a sense of renewed purpose. Like they know the deal. They know what they're supposed to be doing, and they feel renewed, and they know exactly what their purpose is at this moment in time. So they're kind of renewed in what's going on. We encourage mom to focus her energy on pushing We encourage her to rest between her contractions. This stage can be frightening for prima gravidas because they don't know what to expect. And some moms may have a feeling of embarrassment at this point because, her legs are thrown up in front of everybody, everything's all hanging out, and there's a million people in the room, maybe, maybe not. So she may feel embarrassed and a little shy. One thing to note, too, is that the length of this stage of labor, where it says less than 15 minutes to 3 hours, that can depend also on whether you are a prima gravida or a multigravida. So have you done this before or have you not? That can make a difference in the time frame as well. Here are these cardinal movements that I was telling you about. Descent, flexion, internal rotation, extension, restitution, external rotation, and expulsion. You can sort of look at these pictures and just look over that on your own. Like I said, I don't really need you to know that in depth, but you do need to be familiar with the fact that there are such a thing as cardinal movements or mechanisms of labor, and that these things help the baby move through the vaginal canal appropriately. The third stage of labor occurs from the birth of the newborn until the placenta delivers. Normally, this stage is completed within 30 minutes. If the delivery of the placenta does not happen within that 30-minute time frame, then the placenta is considered to be retained. And that oftentimes requires some type of extra intervention from the doctor, whether that be a curettage, a dilatation and curettage of the uterus, so a scraping of the side of the uterus. That could happen either in the labor room at that time, or this person might would have to go down for surgery if the placenta is retained. So it's important for the labor nurse to note the birth of the baby and what time the placenta is delivered, because if we pass that 30-minute mark, then we really get worried, because we don't want the placenta to be retained, because then mom is at risk for hemorrhage. There are two phases of this third stage. We have placental separation and placental delivery. With the placental separation, we have 5 signs this is happening. So these are things the labor nurse can actually see. There's a globular-shaped uterus. The fundus will actually rise up within the abdomen. There's a gush or a trickle of blood from the vagina, and the umbilical cord will protrude from the vagina even farther than it already is. It's important that you know those 5 signs. With the delivery of the placenta, it might come out one side or another. There is the Schultz side, which is the fetal side. This side, if the placenta delivers with Schultz side up, then that means the placenta has separated from the middle of the placenta to the outer edges, meaning separated from the uterine wall. If it comes out Duncan side or maternal side, that means that's the side that was attached to the uterine wall. Then it's separated from the edges towards the middle. And the way we remember that is shiny Schultz, dirty Duncan. And I'm going to show you a picture of this. These signs of placental separation the globular-shaped uterus, the fundal rise within the abdomen, the gush and trickle of blood, and the umbilical cord protrusion usually will appear within the first 5 minutes after delivery of the fetus. So here we go. Dirty Duncan is on the left. Shiny Schultz is on the right. So Dirty Duncan on the left, you can see this is the maternal side of the placenta. This is the side that was attached to the uterus. Shiny Schultz is on your right-hand side. This is the side that faces the baby. And depending on which way the placenta delivers, which side up, whenever it delivers, depends on how it's separated from the uterine wall. Okay, let's go back really quickly. There's also a fourth stage of labor, and this stage is considered the recovery period. This is the first hour up to 4 hours after birth. During this stage, mom can lose anywhere from 250 to 500 milliliters of blood. Fundal massage is very important because we do not want mom's uterus to get boggy. Moms may have a hypotonic bladder during this time, so she may be at risk for urinary retention. And moms are very exhausted, they're hungry, and they're thirsty during this fourth stage. So, moving on to maternal systemic responses to labor and birth. Let's talk about the cardiovascular system. Cardiac output increases during labor and delivery by 10 to 15%. We have an increase in blood pressure, heart rate, and respirations. And why does this happen? Well, it happens because with contractions, 300 to 500 milliliters of blood volume is forced back into the maternal circulation. So we need that increase in cardiac output, that increase in blood pressure, heart rate, and respirations to keep up. And also the moms are having pain. They might be anxious and apprehensive about what's going on. And also this can be affected by the mom's position. If she's supine, then we can decrease that cardiac output and those vital signs. If she's lateral, like left lateral, then we can increase those. The respiratory system, we see an increase in oxygen demand because of the uterine contractions. Moms have an increase in anxiety and pain. They hyperventilate. And then we have a decrease in their CO2 level, which leads to further respiratory alkalosis. You know that moms live in a state of, pregnant women live in a state of respiratory alkalosis anyway. This pushes them further into a state of respiratory alkalosis. It compensates for the first stage development of a mild metabolic acidosis during that first stage of labor. So it's all right. In the pushing stage, we have an increase in our CO2 and our serum lactate. So moms move from a mild respiratory alkalosis now to a mild respiratory acidosis. And then we end up with metabolic acidosis, which is uncompensated by respiratory alkalosis. I don't really care that you guys know the very specifics of those, but I just want you to understand basically that decrease and the increase in the CO2 and what happens in terms of the increase in oxygen demand because of her uterine contractions, that causing the hyperventilation, and then the decrease in the CO2. And then with the pushing, she has that increase in CO2. Usually these things will return back to normal levels by 24 hours post-delivery. So that's what we expect to see. All right. So with the urinary system, we will see an increase in renin level, plasma renin activity, and angiotensin levels. What, babe? Sorry, thought my son was talking to me. It is possibly important in controlling uteroplacental blood flow, intrapartum and postpartum, so that's why this renin level and angiotensin levels are important. These moms may not have an urge to void due to a displaced bladder resulting from engagement. So, for example, as the fetal head starts to descend and engage in the pelvis, the bladder becomes displaced in a way. We want to make sure that the bladder is empty before moms get to a second stage of labor and they start to push. If their bladder is full of urine, it is going to interfere with the baby's descent into the passageway. So we always want to make sure the bladder is empty. We want to offer mom to void or either do an in and out cath prior to the pushing phase or the second stage of labor. And we have to realize that at this point, mom may not be able to tell us that she needs to go to the bathroom because her bladder is displaced in a way because of engagement of the baby, and she just will not have that urge to void. The gastrointestinal system has a decrease in gastric motility and absorption. Nausea and vomiting can occur because of that. And gastric emptying is prolonged, so gastric volume remains increased. And also, if moms end up getting narcotics during delivery to ease her pain, that can also delay gastric emptying even more. So we have a stomach that is not emptying well. We have possible narcotics that have slowed things down even further, which results in an increased gastric volume. And now we got some nausea and vomiting. So we have to pay close attention to the gastrointestinal system when moms are in labor. The immune system has an increase in white blood cells from about 25 to 30 is what we find in laboring women. And this is due to a neutrophil increase from the stress of labor. We all know that stress does crazy things to our body, and one thing that stress will do to your body is cause your white blood cells to increase. So it can be difficult to determine if moms have a true infection, and we want to monitor her blood count levels before and then after labor. If we see that it's slightly elevated, we don't really worry about her having an infection unless she's running a fever on top of that. Then we would start to worry. But it is normal for moms to have an increase in white blood cells directly after delivery. Moms also have a decrease in glucose levels because she uses up all of her glucose during labor, so it's not abnormal to see her glucose levels be less than normal after labor. The integumentary system we find becomes hot, flushed, and diaphoretic during labor. All of that should make sense to you. The musculoskeletal system, we have a hormone called relaxin that is excreted by the body, and relaxin helps to relax our joints and our hips. It allows the bones to soften and become more flexible, the symphysis pubis and the coccyx joints specifically, because our pelvis, the maternal pelvis, needs to be able to expand some to allow that fetal head to come through so that everything can work together. So now let's talk about fetal assessment and response to labor and birth. So how do we perform an in utero assessment? Remember that we don't only have one patient, but we have two. Just one of them we cannot see. So here's what we do. Here's what we do during labor to assess the fetus. We auscultate the fetal heart rate, and that's probably the biggest thing that we do to assess the baby. We can use a fetoscope, which is this picture in on the top left. We can use a Doppler, which is the picture on your right. We also use, mostly in the hospital, we use electronic fetal monitoring. Every 30 minutes in normal labor is how often that we want to get a fetal heart rate. And every 15 minutes in a high-risk patient would be how often we would want to monitor the fetal heart rate. At the bottom here, what you see is an IUPC, or an intrauterine pressure catheter. That's what that picture is at the bottom, and we would use that to monitor contractions. So when we talk about fetal monitoring, we have two different types. We have continuous and intermittent. And we have external monitoring and internal monitoring. So external monitoring is where the TOCO, or the Doppler, is attached to the outside of the mom's abdomen. The Doppler is what measures the heart rate, and the TOCO is what measures contractions. Now, we also have internal monitors. Part of an internal monitor is the intrauterine pressure catheter, or the IUPC, that measures contractions. And then we also have something called a fetal scalp electrode, and fetal scalp electrodes will measure fetal heart rate internally. And we can use a combination of both external and internal monitoring. So we could use an IUPC with an external Doppler, or we could use a fetal scalp electrode with an external tocometer. It just depends. Fetal heart rate pattern interpretation is something that we're also going to talk about. We're going to learn how to read those. And it's very important that you know that there's a baseline fetal heart rate, and then we have periodic fetal heart rate changes, which include accelerations, decelerations, those type things. And some of those we've talked about a little bit in antepartum when we talked about non-stress test and contraction stress tests. So it's important that you don't forget those things. Leopold's maneuver is another thing that we can do to assess the fetus in utero during labor. And the significance of this assessment is that it helps to determine fetal position. Just like a sterile vaginal exam can help us determine the position of the baby, Leopold's maneuver can as well, but probably not quite as accurate. And these are the steps that we use to perform Leopold's. We determine if the baby is vertex or not, and we do that by using our hands on either side of the mom's belly. You can see this in the picture. So that's the first maneuver. Up at the top of her belly, we apply both hands and we see what we feel. The second maneuver is we we use our hands on either side of the belly, sort of more in the middle, and try to feel where the baby's at. The third maneuver, we put our hand kind of right above the symphysis pubis, or whatever the presenting part or engaged part is, and we determine if it's mobile or not. And then we attempt to determine fetal attitude in this fourth picture. So let's go over this one more time. In the first maneuver, we are determining if the baby is a vertex or not. In the second maneuver, we are palpating the fetal back. So which side is the fetal back on, mom's right or left? In the third maneuver, we're trying to determine if the presenting part is engaged or mobile. If it's engaged, that means it's entered the pelvic inlet and it's not going to be able to move. If it's not engaged, you're going to be able to move it around. And then in the fourth picture, we're determining fetal attitude. So is the baby occiput anterior or occiput posterior? It takes a very skilled person to do Leopold's maneuver and really determine all of these different things. It's also possible to do a fetal oxygenation assessment when the baby's in utero. There is something called a fetal arterial oxygen saturation monitoring system, and this does intrauterine monitoring of the fetus. It's a tool that uses pulse oximetry principles, and you insert it into the vagina. It rests against the fetal cheek, and it gives a real-time oxygen saturation reading for the fetus. Normal values for a fetus are anywhere between 40 and 70%. So we are not looking for, 90 to 100% in a fetus. We're looking for something between 40 and 70. A decrease. Oh wait, hold on. I'm skipping ahead of myself here. Another way that we can do fetal oxygenation assessment is through cord blood sampling. So the baby actually has to be born to do this, like you see it here. It's drawn from the umbilical cord immediately following delivery. So the physician will deliver the baby, cut a section of the cord, clamp either end, and hand it to the nurse, and then she will draw a cord blood sample. It's drawn from one of the umbilical arteries, it doesn't matter which one, and then you place it on ice until you can test it. A normal pH for a pH sampling of cord blood is 7.25 or greater. If it's less than 7.25, it means that the fetus was deprived of oxygen during the labor and delivery process. So this can be a very important tool to determine sort of oxygenation insults during the labor and delivery process. And the physicians oftentimes will use it, especially if they have a baby that was showing signs of distress. Excuse me, guys. Showing signs of distress, so that they can determine how bad the oxygenation level or if the fetus became hypoxic. So, we are going to learn how to read a fetal heart rate strip. We've already talked about contractions, so now we're going to be focusing on the fetal heart rate, which is the top portion of that strip. There are some key terms that you need to know while we're learning to do this, and we're going to go over those now. So these are fetal responses to labor. This is the fetal heart rate assessment via electronic fetal monitoring. The first key term that you need to know is baseline. And baseline is the average fetal heart rate over a 10-minute period. And it's rounded to increments of 5. 110 to 160 is normal. Bradycardia is less than 110 beats per minute times 10 minutes or greater. And tachycardia is greater than 160 beats per minute times 10 minutes or greater. Accelerations are an increase from the baseline, and we have two types of accelerations. We have 15 by 15s, which means 15 beats above the baseline for 15 seconds, or we have 10 by 10s, which is 10 beats above the baseline and lasting for 10 seconds. Those are the only two ways that we chart it, is 15 by 15 or 10 by 10. Decelerations are a decrease from the baseline, and we have several types of those. We have earlies, lates, variables, and prolonged decelerations. Variability are fluctuations from of the fetal heart rate from the baseline for 2 cycles or more per minute. And we measure variability in terms of absent, minimal, moderate, or marked. Variability tells us how intact our central nervous system is for the baby. So this is an important factor that we look at to determine, fetal response to different things. If the baby has an absent variability, that's very bad. We like to see it nice and moderate. So let's talk about baseline. Baseline to be able to determine baseline, you have to have 2 minutes of uninterrupted fetal heart rate strip. Normal is 110 to 160, and this is an example of a reassuring pattern. There's a normal baseline, there's good variability, and they're 15 by 15 A cells. So, here's our baseline. You can see this is 2 minutes. There's 2 minutes of baseline right there at least, and it's uninterrupted. And so our baseline is about, 120, 130, 140. Our baseline is about 135, somewhere between 135 and 140. And you can look at the majority of the strip and sort of see where that baseline falls. All of these little squiggly lines coming up and down here are your variability. We're going to talk about that one next. And then your A cells. So here is an A cell. Here is an A cell. There's another A cell. So that is an increase from your baseline. And remember, we only chart them two ways, 15 by 50s or 10 by 10s. So even though this one goes up more than 15 beats above the baseline, and even though it lasts longer than 15 seconds, we still chart it as a 15 by 15. This is what bradycardia looks like. Now you can see that the fetal heart rate is way down here, right? So normal is 110, which would be here. And we are down here in the 70s. This is bad. And there's very little variability. It's very minimal. So this is terrible. Bradycardia means that the baseline fetal heart rate is less than 110 beats per minute for a period of 10 minutes or greater. It can be with or without A cells, D cells, or variables. It's associated with fetal vagal responses, fetal cardiac conduction abnormalities, trisomy 18, and maternal connective tissue diseases. We manage this with intrauterine resuscitation if indicated, and we'll talk about intrauterine resuscitation at the end. This is a picture of tachycardia, and you can see up here our fetal heart rate is at like 205-ish, okay? With tachycardia, the baseline fetal heart rate is greater than 160 beats per minute for a period of 10 minutes or greater. It can be with or without A cells, D cells, or variables. It's associated with early gestation, infections, fetal anemia, fetal cardiac arrhythmias, or fetal hypoxia. And it's managed with intrauterine resuscitation. So, think about all of these things that it's associated with. All right, early gestation. That means a baby that's premature. It is not uncommon to see a premature baby with a very increased heart rate. Infection, anemia, those couple of things, also with cardiac arrhythmia, those couple of things are the same with adults, right? If you have an adult or a child that has an infection, what happens to their heart rate? It increases. And with somebody who has anemia, their heart rate increases. They have tachycardia. So it's the very same with a fetus. And then with fetal hypoxia, if the baby becomes hypoxic, it may be tachycardic initially, but after a period of time, that baby's going to become bradycardic because you can't live hypoxic but for so long, right? Acceleration. Accelerations are an abrupt increase in the fetal heart rate for at least 15 beats above the baseline, lasting at least 15 seconds, but less than 2 minutes. Okay, so we last 15 seconds, but it has to be less than 2 minutes. 10 by 10 accelerations are normal if the baby is 32 weeks or less. Just a little tidbit of information there. These are associated with spontaneous fetal activity, stimulation, and uterine contractions. And this is a favorable response. We want to see accelerations. Accelerations are good. It means that our baby has a positive response to stimulation and activity. So it's very good to see this. Now we're going to talk about the different types of decelerations. Early decelerations are a symmetrical and gradual decrease in the fetal heart rate that has a return to baseline, and these are associated with contractions. Okay? Early decelerations usually mirror the contraction. So, we take a look at this picture, let me find my mouse. Check out this contraction. See, we have the beginning, the end, and here's the peak. Now take a look at your fetal heart rate. Here's the onset of the deceleration, and it goes gradually down. The nadir is the bottom lowest point of that deceleration, and then it recovers back to baseline. Now, if we draw a line straight up from the peak of this contraction, it's going to mirror the nadir of this deceleration. So these two things will mirror each other. Okay? So early decelerations mirror contractions, and they are caused by head compression. We see early decelerations when the fetal head moves into the birth canal and begins to become compressed. As the contraction happens, the baby's head gets squeezed and the heart rate decreases a little bit. But as the contraction lets up, the heart rate returns back to baseline. What this means is that the baby is moving down in the birth canal. We need to monitor this mom closely because she is close to delivery. This is a good sign. We don't mind seeing early decelerations. This is okay. As long as they recover back to baseline, we're good. Now, on the other hand, late decelerations are bad. We do not like to see these. Remember, we talked about late decelerations whenever we went over the contraction stress test. Late decelerations mean that there is uteroplacental insufficiency. That means that the baby has no oxygen reserve to recover from a contraction. So, late decelerations are symmetrical, gradual decreases in the fetal heart rate. They return to baseline, and they are always associated with a contraction. They usually occur after the contraction happens. They are associated with uteroplacental insufficiency, and we manage these with intrauterine resuscitation. The first thing that a labor nurse thinks whenever she sees a late deceleration is placental abruption, because that is the one thing that causes uteroplacental insufficiency faster than anything else, right? So take a look at this picture. We have the contraction down here, and now if we look at our heart rate up here, you can see that our decel doesn't happen until after the peak of that contraction, and the recovery back to baseline doesn't happen until after that contraction is way long gone and over. This is a bad sign. We do not like to see late decels. Make sure that you guys understand what uteroplacental insufficiency means and what it refers to, because I say that term over and over again in this class, and it's very important that you understand what it means and the different things that can cause uteroplacental insufficiency, because it will help you critically think through your test questions and through this information and these concepts. All right, let's talk about variable decelerations. This is our third type of decel, and this is an abrupt decrease in the fetal heart rate. It is 15 beats per minute or greater and 15 seconds or longer, but it's less than 2 minutes. The onset to the nadir is less than 30 seconds, so it's quick. It's an abrupt decrease. And variables can be associated with contractions, but they don't have to be. So we might see variables with or without contractions. In this case, in this picture, we see them with contractions. And you can see that they're almost like a V shape. These are associated with cord compression. So if we have an umbilical cord that is stuck somewhere and a contraction happens and that umbilical cord gets squeezed, it's just like cutting off somebody's oxygen supply. We've, cut off the umbilical cord and the blood flow to the baby. We have a sharp drop in the heart rate, and then once that compression lets up, then it comes right back to baseline. Sometimes babies will actually hold their umbilical cords in their hands, and if they give their umbilical cords a squeeze, then we'll see a little variable. We manage these also with intrauterine resuscitation. And if you think hard about how we would do this, you think about the fact that these are caused by cord compression. Then what can we do to help change that? Like, we can't reach in and move the umbilical cord around with our hand, can we? No, of course not. So how would we manage it for the patient we can't see? Well, we have to intervene with the patient that we can see. And so we would just flip her over. We would turn her on the opposite side, or we might put her in a knee-chest position just to move her however we can to get that cord out of whatever spot it's in. So that's part of our intrauterine resuscitation we'll talk about. Variability. Variability are fluctuations in the heart rate. They can go either up or down. They're less than 15 beats, and they last less than 15 seconds, and they're irregular in their amplitude and their frequency. So they're irregular in how high or low they go and how often they occur. They are classified in 4 ways: absent, minimal, moderate, or marked, and they are associated directly with the fetal central nervous system function. So like I told you, this tells us how well the neurological system is. Is the central nervous system intact? Absent variability is undetectable. It is non-reassuring, and that means that the baby is possibly compromised. We do not want to see an absent variability. That's like seeing a flaccid baby almost. It's not a good sign. Minimal is less than 5 beats above or below the baseline. This is also not reassuring, and this also means that the baby is possibly compromised. Moderate is normal. That's what we want to see, and that's anywhere from 6 to 25 beats above or below the baseline, a reassuring sign. That means our central nervous system is nice and intact. And then marked is greater than 25 above or below the baseline, greater than 25 beats. We're going to look at some examples. So, look here at the top. This fetal heart rate has absent variability. It's just a straight line, pretty much, okay? No detectable variation around the baseline. And you may have to blow these pictures up on your screen to see them. Minimal variability. This, you can see we have no more than 5 beats above or below the baseline in here. You can see these tiny little squiggles here and there. That's a variability. But if we look closely, there's nothing more than 5 beats above or below the baseline, and that's why we call it minimal. With moderate variability, we can go anywhere from 6 to 25 beats above or below the baseline. So take a look at this little dotted section right here. Okay, so here's our baseline. I can't even see a number on there, so I can't tell you what it is, but it looks like it's about, I don't know, 150-ish. And you can see we have this fluctuation up, down, little up, goes up here, comes down some. So we just have this fluctuation in the heart rate where it goes up and down, and this is moderate because it's somewhere between 6 to 25 beats above or below that baseline. And now we have marked variability. So this is almost kind of sawtooth looking. Looks like V-tach almost if you're a cardiac person. This is what a fetal heart rate looks like if it has marked variability. And this can also be associated with fetal complications, cardiac issues. So we don't really like to see this either. It means that there's something not quite right. I'm not going to ask you guys this on your test, but I do want you to be familiar with it, and it is in your book. There is a 3-tiered fetal heart rate interpretation system that is now evidence-based and used in all facilities. And the reason that this was developed is because this makes it very easy to be able to call your physician and say, I have a Category 2 fetal heart rate strip, or I have a Category 1 fetal heart rate strip. And that physician knows exactly what you mean. He knows exactly what that interpretation is, and he should be able to make interventions and come to conclusions based on that report that you've given him. It's just a general way for everybody to be on the same page whenever we talk about heart rate interpretations. And you have to, remember what interpretation means. Everybody's interpretation is not always the same, and that's what we're doing here. This is an assessment interpretation. So this 3-tiered system breaks fetal heart rates down into 3 categories, and I'm just going to go over them quickly with you. Category 1 is a fetal heart rate tracing that includes all of the following. The baseline is somewhere between 110 and 160. The variability is moderate. There are no late or variable D cells, and early D cells can be present or not, and accelerations can be present or not. Category 2 fetal heart rate tracings include baseline rates, bradycardia not accompanied by absent baseline variability, or the baseline may be tachycardic. The baseline fetal heart rate variability, you may have minimal baseline variability, absent baseline variability, or marked baseline variability. And there is an absence of induced accelerations after fetal stimulation. And then we can also have periodic or episodic decelerations, and that has to do with whether or not there are contractions. And then with a Category 3, we have a absent baseline fetal heart rate variability, and we have any of the following: reoccurrent late D cells, reoccurrent variable D cells, bradycardia, or a sinusoidal pattern. I don't need you to know what that is. So what you need to know is that Category 1 is good. Category 2 encompasses pretty much everything that Category 3 or 1 does not encompass, and Category 3 is bad. If we call our physician and tell him that our fetal heart rate strip is Category 3, then he needs to be coming over to the hospital to check it out, because that's a bad thing. Here are some additional resources for you guys in terms of interpreting fetal heart rate patterns. You can go to these on your own and do that extra studying. And now let's talk about intrauterine resuscitation. So intrauterine resuscitation are measures that we take. They are interventions that we do as nurses to respond to a fetal heart rate pattern that is not favorable. So if we see something in a fetal heart rate strip that we don't like, then we use our intrauterine resuscitation measures as interventions to improve that fetal heart rate tracing. And here are the things that we do. We reposition mom. We might put her sideline, or in bad cases, we may put her in a knee-chest position. We give mom oxygen via a mask at 10 liters. If we can increase her oxygenation level, then we can increase the oxygen that gets to the baby through the placenta. We give her an IV bolus because we want to increase fluids. We discontinue any drips that she might be on. If she's on Pitocin or magnesium or an epidural, if she's getting any other extra medicines and the baby's heart rate starts to look unfavorable in any way, we start to see decels or variables, we stop those drips, because that bad-looking strip could be coming from reactions from that medication. So we stop it. We might place fetal scalp electrode. So fetal scalp electrode is something that allows us to internally monitor the baby's heart rate. It's a little device that gets screwed into the baby's head, and you can put that in while you're doing a sterile vaginal exam. To put in a fetal scalp electrode, the mom's water has to be broken. So we would not place a fetal scalp electrode on someone who was HIV positive, for someone who had some type of infection, if the mom was GBS positive. We would not put a fetal scalp electrode for things like that in which we might introduce an infection to the baby. So that's important for you to know. And you have to also know that you can't put on a fetal scalp electrode unless the membranes are ruptured. We might do fetal scalp stimulation. So that's basically where you do a vaginal exam and you start scratching the baby's head. It's pretty much what we do. We stimulate the scalp and hopefully get their heart rate to increase, or get their fetal heart rate strip to look better or have an acceleration. We may have to do an amnio infusion. Amnio infusions are administered through an intrauterine pressure catheter. There's a little hub there where we can hook up an IV tubing and run normal saline into the uterus. And we do that for moms who might have lots of variables going on. And what do variables mean? Variables mean that there's cord compression somewhere. What helps our cord to not be compressed? Amniotic fluid. So we may have to run some extra fluid into the uterus. If we do that, it's very important for us to monitor intake and output, because if we're putting a whole lot into the uterus and nothing's coming out, then we have the potential to rupture the uterus. We might have to prepare mom for a C-section. We administer ordered medications like terbutaline, magnesium, or epinephrine. Terbutaline we would give to the mom who was having too many contractions during labor. She wasn't having enough resting tone. So the pressure in her uterus is building. She's having too many contractions. The baby's not getting enough oxygen because contractions are coming back to back to back. And we may need to give her some Terb to slow her contractions down. Remember, terbutaline is one of those medications we give to preterm labor moms. Magnesium is the same thing. We give it to decrease blood pressure and to help relax the smooth muscle of the uterus if need be. Ephedrine is a drug that we would give to a mom who'd had an epidural and had a drop in blood pressure, or a mom who just had a drop in blood pressure in general. Ephedrine would help get her blood pressure back up, help get blood flowing back to the uterus, back to the baby, and increase oxygen. Another intrauterine resuscitation measure that we need is calling the healthcare provider or the doctor, communicating with our nursery staff to let them know what's going on, what issues we're having, and what type of baby they might expect when it's born. Continuously monitoring the fetal heart rate, so not allowing that mom to be on intermittent monitoring. Checking mom's vital signs frequently. Assessing labor progress. We do that through a sterile vaginal exam. We determine how dilated she is, how effaced she is, and keeping the patient and the family informed of what's going on. So all of those things are intrauterine resuscitation measures that we use as nursing interventions to respond to fetal heart rate tracings and interpretation of those tracings. This is the end of individual module 5.2, PowerPoint 1, and this is lecture 2. Thanks for listening.